Okay. Good afternoon, ladies and gentlemen. I think that it's time now to begin this session, and it's my pleasure to moderate this session with my co-chairman, the Professor de la Monica from the University of Nice. This afternoon we have to talk about HIV as a chronic infectious disease.
So now it's my pleasure to introduce you Frank Miedema from the Utrecht University, the Netherlands. He will focus his talk on chronic inflammation and pathogenesis.
Thank you very much. I don't know how you feel, but after such a talk, to talk about pathogenesis and laboratory stuff, anybody? Let's do it. I've been in this game for a long time, since the early 80s, in fact, and we were at the Amsterdam cohort studies in the beginning. Some of you may know, but some of you may not. And what I'm going to talk about today is not primary data. I'm going to show you the flow of thoughts that people can have if you look at H. pathogenesis now. I think it will also chime in with the next speaker about chronic disease and what is happening in patients. And I will show you a little bit about how we have been thinking and how we are now currently thinking and point out some of the issues. The title of the talk is extremely clear, I guess, that I think the driver of pathogenesis is inflammation, immune activation, and I will show you how we have come to this. And if you think I'm speaking too fast, you're probably right. But everything is in the paper that is published on Frontiers Immunology, which is an open access. You can all go there and have it for free because I paid for you. And it's in Frontiers Immunology HIV/AIDS research. So go there and enjoy. So take it easy, don't take notes, but try to follow the logic. And I have to certify that I have no conflict of interest, really. So just to give you a little bit of background, in HIV infection, of course, we went through several hypes and modes. And in the beginning, we thought that you cannot even imagine anymore, but people like us remember that we used to talk about viral latency early on. This is a little bit pathetic, of course, nowadays, but it's the case. And then we went to clinical latency, which, of course, is all what you know in seropositive individuals. This, of course, was very much driven by technology, the PCR. Some of you may know that there was a time that there was no PCR. And this started in roughly 87. And from then on, the virus was everywhere. Pantaleo, you may all know, JAPI, Pantaleo, and others showed that it was enriched in the lymph nodes. Just all of a sudden, we could also find it there. And still, and this is still true, there's still a relatively low number of infected cells, cells that really produce HIV in a specific time, at a specific moment in the body. And this is still relatively low because the total number of cells that could be infected is 10 to the 12th. So this is still a relatively small fraction of cells producing virus and dying from it. The big change, and I make a lot of leaps here, the big change came with David Hose and George Shaw's paper that some of you may have seen and other people, of course, just know from textbooks. There was Nature 1995, and this is a long time ago already, but still, of course, very important. And these people showed that there was high turnover and there was an enormous amount of virus being produced every day. There was a good logic, and it was sound, and it was very intelligent work. And they also suggested that there was an exhaust. There was also a lot of CD4 T cells being killed every day. So even the fraction is very small. There's still a high turnover of these cells because they live very shortly. I will explain this to you later on. And these two papers had, especially David Ho's paper, had an enormous impact and have still an impact. If you go to the textbooks, this is still what many textbooks show you as the main explanation for why we die from HIV infection. But the textbooks are obviously always wrong, at least for 50%, and you never know which 50% you're in. And this is a scheme that one of my PhD students, who is now a medical microbiologist at the Academic Medical Center in Amsterdam, drew up in her thesis. And this is the model that you can always remember forever. So this is the immune system producing T cells. So say this is a thymus or wherever the T cells come from. And T cells are going into the body, and this is your body, and this is what we look at. Here we look in the blood at the number of T cells. And this is where T cells are dying. This is what Americans say, they go down the drain. And in fact, this is clearly, say, what happens here. And so the idea, of course, in David Ho's, say, very suggestive model, they used tap and drain as a model. They said, well, what is happening here, HIV is killing a lot of cells. The immune system wants to keep the level of cells up. and therefore it's opening up the tap. I have copyright on this slide, by the way, for if you took a picture. This is my only interest I have. So, in fact, so if the cells are dying here, then of course cells are depleted, and you have to open up the tap to get more cells being produced. And of course, obviously, the idea was, at some point in time, this tap is running dry, so there will be no cells coming out of the thymus anymore, and then you see the level of CD4 cells in the body going down, and you're running into problems. You go below CD4 200, etc., etc. Everything from there on is clear. This is a very, very powerful model and has a lot of, say, explanatory power. The idea, of course, here is that if you look at the immune system in this way, and here's the tap, here's the cells being produced, apparently, and here you see how cells proliferate. I'm missing out a slide here. I will take this one. You see here what happens is that the thymus is producing cells. You have naive cells, which are cells that have not seen antigen yet. This is all in the review, by the way. And here you drive these cells to proliferate and go to the memory cell population. You can see that HIV is taking its toll here. So HIV is killing all of the cells that are in proliferation because it's a retrovirus. It can apparently only and best kill proliferating cells. You see a lot of death here. And what is now happening is that the immune system, because it wants to fill up the space here, it wants to fill up and compensate for loss, because this is homeostatic, say, thinking. The immune system is trying to compensate for this loss and starts increasing production. So what you see is cells are being killed and cells are being produced in response to this kill. This is the very strong, say, textbook, say, model now. And of course, it's all driven by cytopathicity. So it's all being driven by cells being killed because they get infected. Of course, we know a lot more now, but this is the very strong driver still in most of the textbooks. And this was, of course, supported by data that came on a little bit later. And this is a very famous paper by John Mellis in Science, where at the time we were just able to measure RNA loads. You could see that people with the highest loads were rapidly losing CD4 cells or dying, and people with the lowest quartile loads survived for much longer. We all use this assay now to predict, say, survival of HIV-infected patients still. And this is, of course, all true, and of course, it all depends on how you interpret the data. From roughly the year 2000, people started to realize there was something else going on. And the something else was immune activation. And also, I'm also guilty in denying that this was very important, because people had always argued there was an enormous amount of immune activation going on, and people like myself and others, so I'm pleading guilty here, we all said this is all peripheral and epiphenomenal, and the real thing is cytopathicity. But at some point in time, we started to realize, and for me the time was 2000 roughly, we started to realize that immune activation might be the real cause why things go wrong. And the logic is that, in fact, we reversed logic. So we reversed the cause and effect. So we found out, and I will show you 2 data slides for that, we found out that increased T-cell division is not a consequence from because there's depletion, but something is driving this immune activation, and as a consequence, cells are dying just in the reversed logic. And this is not what you find in textbooks yet, although there are some good textbooks in my mind. And so this is what people now, of course, believe generally, that increased cell division is pushed by the virus and not pulled by depletion and death and trying to compensate. And this was an insight we got from with Mr. Hazenberg stuff that was done in my laboratory, but also others, of course. Again, David Hoos and also Joe Kovac's lab at NIH, and later on many others. So what was the data? Just look at 2 data slides to get an impression of how you can do your logic. So we started to study with Charles Boucher and other people. We started to study a patient group that were put on saquinavir. It was, you know that, saquinavir. And so we on this axis, you see the number of peripheral cells at the start of the study. And here you see that we measured the number of dividing cells. And what you see clearly is that the lower the fraction of cells in the blood of the patients, the more cells were dividing. So remember, the original idea from the textbook is you kill cells here, cells are trying to compensate. So the more cells you kill, the more cells are trying to divide. So this goes very much with density-dependent growth. This suggests that those cells are dividing because they try to compensate for loss of cells killed by the virus, right? It's all in the review, just follow the logic. And then we started to treat these patients. In fact, we the people in internal medicine clinic, of course. And what we found is that this is the number of dividing cells, and here you see the number of cells in the blood. So, of course, what we know now is that there's only a very gradual increase in number of cells in the periphery, and this is, of course, due to many different sources. But what you see as well is that long before these patients have normal cells again, the number of dividing cells, the fraction of dividing cells, is going down steeply immediately when you start to treat. So it's totally, this shows that those cells are not dividing because they are depleted. No, that if you take the virus away, cells stop depleting, stop proliferating, and the whole immune system comes to rest. And this is the most powerful data. This has been shown by many others since then. This is the most powerful argument that indeed the virus is pushing proliferation, and those proliferating cells are just dying because of contraction. I will show that slide later on. And this was supported by data from others that when you do multivariate analyses, and you put in the model CD4 RNAs, a number of activated cells, D-dimers, whatever is immune activation markers are always stronger than CD4 and RNA, always. And this has been published by especially Janice George's group from UCLA, and unfortunately Janice died later on, but she was really the first to show that this was really going, and this laboratory, UCLA, Janice George and John Fahey, have been working all the time, and all the time saying to us that immune activation was there and was very important, and we have been denying it until 2000. Again, this is the second time I plead guilty here. But Janice has not seen her fame now because she already died before because of breast cancer, which is very, very unfortunate. But later on, people like Steve Deeks, they published the same papers. And this is San Francisco City cohort. This is Amsterdam cohort studies. We show the same. So clearly, immune activation markers are dominant in models to predict time to death and time to CD4 below 200. So there's something completely different going on. And the most interesting part is that in SIV infection, you know the model in Suter-Mangabees. This is a natural infection in Suter-Mangabees with SIV. These monkeys have high viral loads. The virus is cytopathic, as is a human HIV for CD4 cells. There is some transient immune activation, but then it goes away. There's no CD4 decline, and the monkeys don't die. And these monkeys have very high viral loads, very high viral loads. This is the claim to fame by Silvestri and Mike Feinberg, who is now with Merck. Go to these papers and see how extremely strong the data is. So if you don't have an immune response, if you don't have immune activation, you can have a lot of infected cells and you can have viral load, but you don't die. This goes against the cytopathic dogma, of course. And so people say, okay, but how can you then lose your CD4 cells? Well, if you deplete your I'm lacking a slide. If you deplete your immune system from resting cells, for instance, if you push the whole system to the right, I will go back to that slide. If you push the system to the right on my slide, if you push everything to the right, in the end, you're lacking memory, resting naive cells and resting memory cells, and you get depletion because these cells are very hard to replenish because, especially in adults, these cells are only made in very small amounts every day. So this is a very simple, banal explanation, you could say. There's a lot of evidence for this, and I will cite, this is all cited in the review, and you go to the review, you see all the logic. Of course, what is now causing this immune activation? We, of course, all started on adaptive immunity, T cells, and T cells. CD4 and CD8 T cells, this was what we talked about. But later on, of course, there were other things that and I will show you the data for that. We found out there were, in fact, 3 ways that the immune system can be activated, and I ranked them for you according to the contribution that I think that they make to this pathogenic effect. In the first instance, we know now since 2007 that soluble single-strand RNA are activating human leukocytes via toll receptors 7 and 8. This has been well published, but not everybody has picked this up. And the other thing, of course, we know that there's a lot of activated antigen-specific cells, and of course, we know that there's bacterial products because of bacterial translocation, because HIV is causing a breach and of integrity of the gut. I will go very quickly into this. Go to the review, you see all the references, there's boxes, everything is there. But clearly, HIV is directly activating via single-strand RNA, via toll 7 and 8 on human, especially human plasmacytoid dendritic cells. Those are the cells that make most of the type 1 interferon. These are the cells that start immune activation. Also in flu, SARS, or whatever you. And these are, of course, also on NK cells. And the other thing is, of course, that we know now that this activation results in a massive and an uninhibited type 1 response. There's a lot of information in the literature for that. Go to the review. And this is not down-regulated. And there's data by Bargewire, Gene Shearer, Marcus Altfeld, and many others that show very clearly what is going on. And this was, of course, not discovered by HIV researchers, but in 2004 and 2005, there were 4 papers in Science showing that also other viruses activate via these receptors by their single-stranded RNA. So this is a common thing for viruses. And this starts immune system, danger signals. And finally, of course, very interestingly, people from Mark Feinberg's lab, and this is a very, very heavily contested paper, showed in Nature Medicine and later in Journal of Immunology that SUTIs cannot produce a lot of type 1 via these activation pathways because there's apparently one of those proteins below in the chain has a mutation. This is heavily contested, not accepted by everybody, but extremely strong data. Go to these papers by Mark Feinberg. Judith Mendel is the first author. And of course, we know that CMV and normal antigen can also have an effect. So why do I think, and then of course the other thing is bacterial translocation. You know a lot about it. You went to all these meetings. Danny Dueck and of course Stephen Deeks have been talking about that. Go for the recent review in Immunity, which is not open access, by the way. Go to Immunity and see what they have to say about that. Why do I think that this is less important, although very, very interesting? Because as soon as you start to treat HIV-infected patients with heart, you see that most of the immune responses go down. This is not from our work, but this is from Marcus Altfeld's work. Marcus Altfeld is now back in Hamburg, and they showed this in 2007. This is a very good, very strong Journal of Virology paper. Go to this paper and see all the evidence. So as soon as you treat somebody, most of the immune activation is gone. So what happens there, you take away the virus. At that point in time, also because of the work by Deeks and Dueck, we know that at that point in time, there is still LPS in the system, there is still integrity breaches from the gut that takes for years before that is repaired. And so clearly this argues, and this is also what these authors argue, this is clearly something which is driven by HI single-stranded RNA from the virus itself. Okay, then of course this is a complete, if you go, this is also from the review, you see there's a complete picture where everything starts with bacterial products, with the 7 and 8 and 2, 4, 5 and 9 toll-like receptors. So toll-like receptors extremely important in the immune system, drives everything. Everything starts with this. There's no immune response without activation. And so this goes down to all kinds of activation markers, IL-12, IL-6, TNF, everything is being driven by type 1. And also, of course, there's also clearly direct effects of bacterial products in this loop. And then, of course, this also goes to end organ disease. I think the next speaker will talk about that. So the whole idea of HIV is not it kills CD4 cells and therefore you're running out of CD4 cells, but this is a massive immune response to the virus, both adaptive, both innate, and this is doing you in. And there's an enormous amount of evidence in the literature already long before toll-like receptors were discovered that people show this and have been showing this over and over again without us being able to understand and have a proper interpretation for this. Of course, this type of immune response is blowing away the CTL responses to HIV and the CD4 responses. And as soon as you start to treat, you see the CD4 and CTL responses coming back. And this has also been well documented by many investigators. And these data have been debated forever. How should we interpret this type of responses? The responses just come back because inflammation is going down. And this has been shown by many others. So finally, of course, if you know all this, we have to reconsider. So forget about therapeutic interventions. That would be very unwise because activating the immune system even more is not very helpful. And this, of course, is now nearly abundant, I guess, in the literature. Of course, think about, do you want to relieve T cell, say, energy? Do you want to potentiate T cells in these patients? Do you want it? For cancer, I would say yes. But for HIV, leave those energetic cells there because you love them. If you're the patient, at least. And of course here, go for anti-interferon alpha, go for blocking of T-cell receptor pathways, and go for other kinds of therapies that can interfere with this type of responses. Finally, this is of course not done by myself. There's a group of people. We have been working for a long time on this. And eventually, of course, the last slide, and this is probably the bridge to the next speaker, I don't know, but this is of course the residual and low-level immune activation is going on. And this could very well be by LPS or bacterial translocations. And this is low level, but has a gradual effect in patients in the long run, even if they are on complete heart. And I will leave you here. So all in the review, digest, write me an email if you disagree, take your time. Shall we do it like this?
Maybe we have a question, no? No question?
No question.
Not at all?
So you are...
Okay.
Are you activated?
Still activated. So now it's a pleasure to have a communication by Paddy Malone from Dublin, who is going to talk about aging with HIV. So thank you very much.
So thanks a lot. Thanks to the last speaker for a fantastic overview of the inflammation associated with chronic HIV, which forms the basis of a lot of this presentation. And also thanks to Alain and the organizers for the very kind invitation to come back to Marseille to speak. I'm going to bring you on another very rapid-fire journey around aging with HIV. First of all, in contrast to the last speaker, I'm heavily conflicted, but I think evenly conflicted. So the basis of this talk in terms of people getting old with HIV is really a reflection of a success story. One of the things when you first come into the auditorium, I don't know if you saw the video, it's sort of very ominous background music and paints growing old with HIV as something that's going to be very abnormal and very negative. But in effect, what we're dealing with is a very positive response to really the advances that we've made in this field over the last 25 years. And we should be enforcing that with our patients, that growing old with HIV is a success story. The reason it's a success story is because of the effectiveness of antiretroviral therapy. This is one of the first studies now, for a combined study from the SMART and the SPREE trials that's looked at a group of people with good CD4 counts on effective antiretroviral therapy who are virally suppressed. And it actually shows that if you have a CD4 count of greater than 500 on effective treatment, that you can expect mortality to be roughly equivalent to what's expected from the general population, which to me is good news. The bad news is the fact that if you don't attain that CD4 count of 500, if you've got a CD4 count of less than 500, despite effective therapy, you still experience excess mortality. And when you look at what drives that excess mortality, it's really driven around diseases such as cardiovascular disease, a common disease of aging. We know that patients in general are getting older. In the US, currently, it's suggested that a third of patients are over the age of 50. That's expected to grow to more than half of patients by 2015. And there's a lot of groups around the world that have data like the Chelsea and Westminster cohort that show that it's really the group of patients between the ages of 40 and 50 that comprise the majority of our current patient population. So we're going to see a large number of patients enter that over 50 mark within the next few years. And that's going to drive concerns around diseases such as cardiovascular disease and bone disease that are normally seen with aging. Data from the Swiss HIV cohort looking at a number of different clinical endpoints, including things like osteoporosis, myocardial infarctions, CVAs, have shown increased incidences of these diseases in patients as they get older, which isn't surprising when you consider that a similar thing would be seen in the background population. But what I want to suggest to you at the minute is that growing old with HIV, specifically in relation to diseases such as bone disease and cardiovascular disease, is very different than growing old without HIV and experiencing these diseases, because the pathogenesis of these diseases in the setting of HIV is so different. So the three things that I want to cover in the next 10 minutes or so are immune dysfunction associated with aging, and a lot of that's been covered by the last presenter. Touch a bit on bone disease and finish up with cardiovascular disease. So in terms of immune dysfunction, we've already heard a lot about the variety of defects that drive exhaustion in the immune system in the setting of chronic HIV infection. And certainly when you look at a lot of different markers of immune function. The immune profile seen in patients that are HIV infected would certainly be similar to those that are seen in uninfected patients as they advance. And this would certainly be a profile that would fit with a premature aging phenotype in terms of patients' immune systems. I want to focus on the CD4-CD8 ratio because we've always been focused on measuring CD4 counts in patients that are on treatment. But there's a growing body of evidence now to suggest that the CD4-CD8 ratio, in fact, in patients who are on successful antiretroviral therapy may actually be quite a good predictor of long-term outcome. And we really have a very poor understanding in terms of what are the best immune predictors in patients on treatment that will drive their longer-term outcomes, especially as they get older. So to look at this in a bit more detail, in the Mater Hospital where I work, we looked at a cohort of about 190 patients. And as part of their routine clinic attendances, we were able to look at the CD4-CD8 ratios, but we were also able to do a bit more delve into their normal CD4 and CD8 T cells, looking at naive and memory T cells. As expected, only about a quarter of patients actually got a normal CD4-CD8 ratio on treatment, which we regarded as a ratio greater than 1. Now, interestingly, when we looked at the responses, what we found was that those who attained a higher CD4-CD8 ratio actually had both higher levels of naive CD4, but also naive CD8 cells. And probably not surprisingly, those with a greater proportion of effector memory cells ended up with lower CD4-CD8 ratios. But importantly, what we found is that the strongest predictor of a higher CD4-CD8 ratio on treatment, which may predict a better clinical outcome, was actually the proportion of naive CD8 T cells. So this sort of pushes us away from the sort of focus around CD8 and maybe suggests a greater role for immune activation markers such as CD8 cells and potentially the role of naive CD8 cells in driving better immune responses to patients on antiretroviral therapy. Whether this has implications for what is the best marker to choose from an immune perspective to decide when patients should go on treatment in terms of their subsequent responses to treatment remains to be determined. But I think over the next few years, we'll probably see a lot more data in the realm of the role of the CD4-CD8 ratio in predicting outcome and those factors that will predict a better CD4-CD8 ratio response on treatment. Now, in terms of the inflammation perspective and its relationship to long-term comorbidities, although we heard a lot about the CD4 cell, we saw that the immune activation around CD4 cells dropping off with antiretroviral therapy. What I would like to propose is it's really the monocyte that is the main cell that's at the center of a lot of the inflammation-related defects that we see in patients as they grow older with HIV. Monocytes are important because activated monocytes tend to migrate to the endothelium. Monocytes retain cholesterol, and cholesterol-laden activated monocytes in endothelium drive atherosclerosis. Monocytes have also been associated with a variety of other end organ diseases, including neurocognitive impairment, and they can be activated through a lot of different mechanisms, not only direct activation through HIV, but indirect activation through CD8 T cells, and also activation through the gut through LPS, which was discussed by the last speaker. Now, in terms of the monocyte activation, you can imagine that antiretroviral therapy could abrogate this effect on monocyte activation, but it will have absolutely no effect on the LPS-mediated activation. And certainly the early studies that we performed in this field would show that HIV-driven effects on monocyte activation do improve with treatment, but markers of LPS-driven monocyte activation really aren't impacted by antiretroviral therapy. And as such, this could explain why we get persistent immune activation in treated HIV infection and how this could impact on onward end organ diseases. So bone disease, well, there's a lot of studies now have shown low bone mineral density in HIV. This is a study just recently accepted to AIDS from our group. A large study called HIV Upbeat, which looks prospectively at a group of HIV positive and HIV negative subjects. And we've shown at both the femoral neck and lumbar spine that those with HIV have lower BMD than those without HIV. What we were able to do within this study, because the control group was drawn from the same population, is that we were able to control for a lot of the generally regarded traditional risk factors for low BMD. And even when you control for all of these risk factors, HIV is still an independent predictor of low BMD. So this is not an effect driven by issues such as age, gender, or BMI. So what drives this low BMD in HIV? Well, antiretroviral therapy is certainly implicated. All studies of patients starting treatment have shown a significant drop in BMD with treatment initiation. And depending on the type of antiretroviral therapy you start, you can experience a greater or lesser loss of BMD. So for example, if you start treatment containing tenofovir, you'll lose more BMD. If you start treatment containing the integrase inhibitor therapy, you'll lose relatively less BMD. But to date, no study has shown an antiretroviral regime that has not been associated with decreases in BMD with initiation. More important, recently published data would show that this is not an effect of first-line therapy, it's also seen with second-line therapy. So in patients that are viremic, starting treatment, they lose bone density, whether it be in a first-line setting or subsequent second-line setting. In contrast, where you're switching treatment in patients that are aviremic, you don't tend to see changes in BMD other than in the setting of tenofovir use. So if you switch away from tenofovir, you gain bone density, while if you switch to tenofovir, you lose bone density. So what this would suggest that it's really the viremic episodes that are associated with the greater loss of BMD. The fact that it's seen with all antiretroviral therapies would suggest that, at least in part, it's probably driven by either virological or immunological components, but we don't quite understand the exact mechanisms underlying these changes. The model that's been proposed for this, therefore, is that you have a group of patients who may be at greater risk of BMD, who lose BMD with both first and second line therapy, potentially additional losses with switch depending on whether or not tenofovir is involved, and as a result, you end up with patients overall who have much lower BMD than their HIV-negative counterparts. Why this happens? Well, it's all driven by bone turnover. Bone turnover is much higher in patients with HIV. The architecture of the bone as a result of this increased bone turnover is more abnormal, and as a result, patients can end up at greater risk of fracture. Can we avoid the drops in BMD that are seen with antiretroviral initiation? Well, the ACTG study tried to use vitamin D and calcium around the time of antiretroviral initiation to try and abrogate the drops in BMD, and they were partially successful. So those patients who were randomized to calcium and vitamin D experienced less bone loss with antiretroviral initiation compared to those patients who were randomized to placebo, but they still lose bone, albeit to a lower extent. In terms of fractures, well, traditionally we talk about hip fractures and vertebral fractures in the setting of osteoporosis, but they're really only seen as patients get into their 70s and 80s. In our patient population, you really should be looking at tibular and fibular fractures or wrist and forearm fractures, because they're the osteoporotic fractures that commonly occur in those that are in their 40s and 50s. And the data so far would suggest that that is the case. This is a combined analysis of the Hop and Son studies, where they looked at just over 1,000 patients, did a DEXA scan, followed them over time, and looked at incident fractures, and they found that there were incident fractures, mostly around the hand, wrist, and foot, and that these fractures were independently associated with low BMD. So the low BMD that we're seeing in our patients is clinically relevant and probably does require treatment. So just to finish on cardiovascular disease, myocardial infarction is commoner in patients living with HIV. A number of studies have shown this. There are a lot of conditions that can impact on our cardiovascular risk. Traditional risk factors are much more common in those living with HIV, but we know that traditional risk factors probably underestimate the amount of cardiovascular disease that we're seeing. So if you just look at traditional risk factors alone, you underestimate the MI rate in HIV by about 10%. So what drives that 10% gap? Well, it's probably all the problems here. We have drug toxicity. We're all familiar with the DAD study showing associations between abacavir and some of the PIs in myocardial infarction. We have more recent updated results from the DAD study that look at the post-2008 era when there was less abacavir prescribed in those with high-risk cardiovascular disease, yet we still see this persistent effect of abacavir exposure in cardiovascular disease. We also have issues around dyslipidemia, and here there are two different types of dyslipidemia. We have our legacy cohort. So we heard the first speaker talk about the adolescents coming through with HIV that experienced a lot of drug toxicity. These patients will have high cholesterol and high triglycerides, but when you look at more contemporary HIV cohorts, dyslipidemia is less of an issue. And the main dyslipidemia that we see within the HIV upbeat study is low HDL. If anything, patients who are HIV positive have lower LDL than patients that are HIV negative, but they also have lower HDL. And low HDL is an independent predictor of cardiovascular disease. Having a HDL of less than 1 is associated with a high risk of cardiovascular disease, regardless of what your total cholesterol is. What drives the low HDL in HIV? Well, we're back to the monocyte, the same cell that drives a lot of the immune activation. HIV infection itself blocks cholesterol exit from monocytes, which is what HDL is comprised of. Therefore, these monocytes are more lipid-laden and therefore more capable of driving atherosclerosis. What about inflammation? Well, we're back to the monocyte, and really it is about, the story is evolving about the monocyte and cardiovascular disease. When you look at markers of monocyte activation, soluble CD14, which is driven by lipopolysaccharide or bacterial translocation, and soluble CD163, which is probably more a reflection of HIV-driven monocyte activation. Both of these correlate with subclinical markers of cardiovascular disease, such as carotid intermedia thickness or coronary artery calcification. So this is an evolving story that would suggest that it's really understanding what goes on at the level of the monocyte is going to be important if we're going to bridge that 10% gap. Now finally, I just want to bring up the issue around premature aging. We need to be careful with these conditions that we don't alarm our patients, and certainly from the immune phenotype it would suggest that there's a premature aging. But for the other diseases that we talk about, we need to be able to differentiate between accelerated aging, which is where patients experience clinical endpoints at a younger age than would be expected, or accentuated aging, where patients experience elevated incidence of these endpoints or these clinical diseases, but at the same age as would be expected from the general population. And certainly, analyses within cancer and HIV would suggest that we're not seeing a premature picture, we're seeing more of an accentuated picture. And we need to be careful that when we look at our patients that we do the properly designed controlled studies to be able to establish relevant clinical endpoints and be able to determine if we have a premature aging phenotype or just an accentuated aging phenotype. However, as for the dyslipidemia, there is a legacy cohort. There are a number of patients out there who have experienced considerable drug toxicity, and they will be very different from patients who are starting more contemporary, safer regimes. And it's likely that those that have lingering mitochondrial toxicity with the extreme dyslipidemia and insulin resistance will carry with them an accelerated or a premature aging phenotype. So how do we manage aging in HIV? Well, the important thing is that we need to recognize the comorbidities. We need to be able to screen for them. From what I've told you, you can see the importance of promoting lifestyle changes, specifically smoking cessation. We need to try and reduce the pill burden and the risks of polypharmacy, and we need to have an appropriate way of managing these comorbidities. And many HIV centres now, recognizing the complexity of growing old in HIV, are actually establishing aging HIV clinics where they will get the input from other specialists outside of the area of HIV to appropriately manage patients as they get older. In terms of research, we have a lot of studies underway at the moment. We're involved in a study called POPPY, which is in the UK and Ireland, together with Peter Rice's HIV cohort in the Netherlands. These are cohorts specifically looking at clinical endpoints in those over the age of 50 living with HIV. They are appropriately controlled with HIV-negative groups, and I think they'll give some very valuable information over the next couple of years. And with that, I'd like to acknowledge my research group and thank you for your attention.
Thank you. Thank you very much for this great talk. I think we have some time for questions. Please don't go, please. First, just a remark. I think that we have to now have to know for patients the cumulative exposure to ART regimen for each of our patients. And I would ask you do you think that we have to recommend or modify guidelines for patients over than 50 or 60 and to avoid, for example, some specific drugs? Do we have to do that?
I mean, it's a very good question. It's something that comes up certainly at the EACS discussions quite often. The approach that EACS has taken to this, which I think is a reasonable approach, is that rather than specifying guidelines for over 50s, we try and specify guidelines for specific conditions. So, for example, for the first time, we're making recommendations about antiretroviral use to maintain bone health. Similarly around cardiovascular disease also, because not everyone who's growing old will end up with these comorbidities, and we have a large proportion of very healthy people who will grow hopefully to a very healthy old age, and I think specifying specific ARVs for otherwise healthy people may not be the best approach. So I think the EAC's current approach is probably more pragmatic.
A quick remark. Thank you very much. Thank you for your excellent talk. So I've discussed this with Peter Reis a lot at home in Amsterdam. Why did people decide to call this aging anyhow? Because this is just inflammation. And of course you could argue that inflammation is driving aging. There's more types of aging than only inflammation. So why are people just not going away from the idea that this has something to do with aging? This is just chronic inflammation and everything what comes with it. And then you can escape from the idea that people are, say, prematurely aging. They just have chronic inflammatory diseases.
I think the what's useful in terms of coining this under the heading of aging is that when you look at the gamut of diseases the patients experience as they age, not all of them are immune driven. So certainly the immune phenotype looks to be an immune phenotype that would be consistent with premature aging. What we're seeing at the bone level really isn't. What we're seeing at the bone level is a very discrete effect that happens around the time of ARV initiation, but it's something that you then end up carrying with you and in terms of defects, not only in bone turnover, but in bone mineralization and architecture. Also, when you look at other things like neurocognitive impairment, I think that there really isn't sufficient data within older people to be able to define that properly and to define whether or not we're looking at an inflammation or whether or not we're looking at something that's drug-driven. And the other big issue is, outside of this, you have a huge gamut of psychosocial issues that we haven't really explored that are very important for people as they get older, together with the issues around pharmacokinetics and polypharmacy. So from that perspective, although inflammation is important for some of the more important clinical endpoints that we're looking at, there really is a field of research that goes beyond the science into the patient, but also into society, that also needs to be examined, and these larger cohorts are established to do that.
On your third slide, if I remember, you show that there is a platelet activation in relation with art. Can you precise the kind of effect and which compounds are involved in this effect?
Again, in the interest of time, I wasn't able to go into that in some detail. When you look at untreated HIV infection, there is platelet activation. We published that back in, I think it was 2010, where we looked at abnormalities in platelet function in people who were naive versus people who were HIV negative. When you look within the treatment setting, a lot of those platelet activation markers settle with treatment. But when you look in a treated cohort, there's certainly more platelet activation in patients who are prescribed abacavir versus patients who aren't prescribed abacavir. We published that for the first time back in 2010 in JID. We believe that platelet activation is what drives the abacavir effect that we see within the DAD study, which has persisted even though abacavir is prescribed less in those that are high risk. So we certainly think that's a valid mechanism, and there's a number of different publications now that have been produced that would support that argument. So that seems to be the story around platelets. The other thing about platelets is monocyte activation drives platelet activation, and platelet activation is important in the pathogenesis of the acute myocardial infarction. So I still think there's something, that part of the story still needs to be told in terms of at a cohort level, whether when you get someone on treatment, their platelet function returns to normal, or whether or not they require additional monitoring or maybe additional treatments to try and prevent the bad effects of platelet activation moving forward.
Okay, so I have another question about testosterone. What do you think of this effect?
Testosterone?
Yes.
We've spent a long time looking at testosterone within our HIV upbeat study. We don't tend to see specific differences in testosterone levels between those that are HIV positive and HIV negative. I think the testosterone story is certainly within the legacy cohort, for example. We have a lot of adipose tissue metabolism and a lot of disruptions in adipose tissue metabolism. Because it's a steroid-based hormone, you will get defects there, but we certainly haven't found anything within a contemporary treated population raise flags that it's a significant issue, although for specific patients it obviously is.
Okay. So thank you very much. So we go on the next presentation. We will make by Julio Montaner from British Columbia. Thank you very much for... I'm sorry.
No.
So I think you have the same presentation.
Yes.
Come on.
For this doesn't work. Thank you very much, Mr. Chairman. I want to start by thanking Alain Lafeuillade for inviting me again to speak at this meeting. And I'm actually giving 2 talks. I'll try to do it in a time of 1. I'm taking over Julio Montaner's talk, and I'm also going to talk on treatment as prevention, a talk I was supposed to give tomorrow. So, can we have the first? So I'm first going to talk on treatment as prevention, or art as prevention, opportunities, challenges, and predictions. And this topic is, of course, highly related to keeping people in care, linking them to care. And one of the good things we've seen over the past 2 years is really the convergence of guidelines. The latest US treatment guidelines say that therapy should be offered to all HIV-infected adults and adolescents, regardless of CD4 cell counts. And in fact, WHO guidelines are coming quite close to that now. And we're finally entering a stage where double standards with regards to regimens and when to start treatment are less and less acceptable. If you look at the WHO guidelines, they're not quite as progressive as the US and certain European guidelines. But if you look at the category here, so less than or equal than 500 CD4 cells, and then you see all the exceptions, people who can be treated immediately, it almost amounts to treating all HIV-infected persons, which hopefully will be the WHO guideline next year. So the WHO guidelines already almost amount to treatment as prevention and treatment for everybody. And interestingly, there's you may have missed it, but there was a letter in Lancet from 2 Yavi cohorts, which looked at the time from infection to reaching a CD4 cell count of less than 500. Now, these are 2 African cohorts. You have to keep that in mind. But in these African cohorts, that time, the median time was only 6 months for men and 8 months for women. So it really, it's really totally useless to wait until the CD4 cell count is less than 500 in these subjects, because the opportunity of sending people away when they are in clinics and they often have to walk far, etc., outweighs the savings by far. Here we have a slide that has been shown many, many times, and in fact the father of this study, HPTN 052, is sitting here in the audience, and that was a dramatic event, the first randomized controlled study showing that if people take antiretrovirals, that they don't transmit the virus. This was in discordant couples, of course, and you'll hear much more about it tomorrow. In fact, we could have known this many years before. This HPTN 052 was presented in 2011 or 2010 in Vienna, or was it in Rome, Mike? Rome, good. But we could have known that, of course. These are data from the Rakai district study in the paper by Tom Quinn in New England Journal of Medicine in 2000, showing that people who had less than 400 plasma viral load, less than 400 copies per cubic millimeter, actually, in the absence of antiretroviral therapy, did not transmit. So why would it be different for people that you give antiretrovirals and you suppress the virus to even lower levels? The person who puts treatment as prevention firmly on the map is actually the person whose talk I'm taking over, Julio Montaner. He published a paper in 2006 pleading very forcefully for expanding access to treatment to prevent new infections. And he was at that time, many people were actually saying that he was crazy. But he was not the first who suggested this. In fact, several people in the early 2000s already wrote papers where they said we have to treat people And widespread treatment would actually be able to have a major impact on the epidemic. But they didn't make as much noise as Julio. So you see how important it is to make noise when you firmly believe in something. And then WHO, that was first denouncing Julio, of course, in 2006, in 2010 came out with a model that showed that if you took South Africa and you would test every person older than 15 years every year and put them all on treatment, that you could almost wipe out the epidemic in South Africa, bring back the prevalence of HIV to less than 1% within 50 years. Very optimistic model, because the model rests on assumptions which are really not realistic. It assumes that it's possible to test the whole adult population every year, that every individual found to be HIV positive will accept immediate antiretroviral treatment, which of course is not going to be the case, that those accepting antiretroviral treatment will all be therapy adherent, that there will be no drug stockouts, and there are often, certainly in sub-Saharan Africa, including South Africa, stockouts are the order of the day, and there will be no development of antiretroviral drug resistance. So very optimistic model, but it was very important at the same time that WHO dared to stick out its neck and really move the field in that way. And I heard that Bill Gates actually took a plane to Geneva to shout at Kevin de Kock because he was so anti-treatment that they had dared to publish this. And then, of course, came the HPTN 052 study, which was the definitive proof that treatment is a good preventive tool. There had been, a year before that, a study had been published which was randomized not to, they didn't randomize to antiretroviral therapy or not, but to acyclovir. Extremely silly in my opinion, a waste of money. But what was nice was that the study actually showed that in couples, if the positive partner was, the HIV positive partner was taking antiretrovirals, they had a 92% reduction in transmission, so very similar to HPTN 052. And now we have evidence from population data, the nicest evidence actually coming from KwaZulu-Natal, published in Science in 2013, where they showed that with every 10% increase in antiretroviral drug coverage, there's a 17% decrease in individual risk. So very convincing evidence that at a population level you can bring back new infections by expanding treatment. And these are data from a recent paper by Julio, data from British Columbia. As you know, Julio runs British Columbia as far as HIV is concerned. What it shows is that these are the years. So here you see a dip in treatment coverage. It's CD4 cells, so a dip in the number of CD4 cells, and we've all had that in our countries because of the toxicity of the early regimens. But then you see over the past years, actually, the CD4 cell count has been going up and is now nearly 400 when people start. Of course, still not high enough, but that's the way it is. And then here, the data on adherence, and you see that actually over time, adherence is increasing to more than 95% in the majority of subjects. And that obviously one of the causes for that are the simple, well-tolerated regimens, the single tablet regimens. In this slide looks at drug resistance, and a lot of people were concerned if you start to treat earlier, you will see more drug resistance. But in fact, if you look at British Columbia, and also if you look in most countries in Europe, there's actually a decrease in drug resistance over time. So, I'm sorry. So these are people with wild type virus in the treated population. And then if you look at, so this is treatment coverage, increased coverage. If you then look on new infections, you see on HIV incidence, you see a decline. If you look at, these are injection drug users, you see a very strong decline in British Columbia. They've done a really good job to have quite a few injection drug users, but they've really targeted that group. And if you look in MSM, it's a little, it's actually not, it hasn't changed a lot. And that's very similar to what we are seeing. We have to realize when we talk about treatment as prevention, what Julio originally meant was not only the prevention of onward transmission of HIV, but first and foremost, the prevention of HIV-related morbidity and mortality in HIV-infected persons. And I think TASP is a bit of a misleading name because it puts the emphasis on prevention, and prevention is a secondary benefit. What you really treat people for is for their own individual health, which means as early as possible, and that works both ways. So I think it would be better to speak for treatment, about treatment for treatment, and in addition to treatment as prevention. Why should we start early? Well, I think you've seen a lot in the two prior presentations. The biological plausibility that early treatment is good as long as the drugs are relatively safe is enormous. You have this continuous immune activation, the virus is doing havoc all the time. Why would you not treat if you have safe and effective drugs? And this is also from the DAD study that was also shown by Dr. Mellon, data from the DAD study. And if you put, and what you see is that if you take this as the reference point, the CD4 cell count of 500 or more, you see that there's a lot of excess mortality, not only due to HIV-specific causes, but also to all these other causes, liver disease, cardiac disease, cancer, etc. And that's what we have seen also in the talks from the two previous speakers. So you're doing much more harm than just ending up with AIDS. And a recent paper in CID actually showed that the incidence from cohort studies, the incidence of AIDS-defining illnesses, in particular malignancies, was higher in individuals with a CD4 cell count of 500 to 750 than in those with higher CD4 cell numbers. There's overwhelming evidence that early treatment increases survival. In fact, various cohorts have shown that when treatment is started early enough and the CD4 cell count is kept above 500, life expectancy doesn't differ from that of the non-HIV infected. And this is another strong argument. These are data from the HIV Monitoring Foundation. In the Netherlands, every patient is on treatment is being followed. And what you see is that people who start treatment with very low CD4 cell counts, it takes an enormously long time for them to reach this 500 threshold. So they're in a danger zone all this time. And that's why I think we see all this excess mortality now from cancers, from other diseases. There's no immune reconstitution syndrome. It may not be so important here in Europe, but in Africa it's a big killer. People come very late, they get immune reconstitution syndrome, they don't have the health system to cope with that, so that's an important reason. And it reduces TB incidence, also not so important here maybe, but extremely important in Africa, especially in southern Africa. And here you see a slide from Robin Wood's group showing what happens to TB incidence after initiation of HEART, and after 6 months it's almost back to the levels in the non-HIV infected. And there's another reason to start early, and maybe that's the best reason. It may actually, if you take people with acute HIV infection, hyperacute HIV infection, it may lead to a functional cure in a subset of those patients. And one may maybe they're not, most of those will not be really cured. I think we have now 2 or 3 cases where a functional cure is probably a real cure, the baby, and then a former Berlin patient, not the later Berlin patient. But a small reservoir actually will make it easier to achieve a real cure in these patients than a large reservoir. The most convincing data are from Thailand, from a study done in the Thai Red Cross, but funded by the US military, done by Jintanat Anavoranic. And here you see the depletion of CD4 cells in the sigmoid during acute infection. Now, this is HIV negatives. So if you treat people very early, phoebic 1 or 2, 1 to 3 weeks after infection, there's very little loss of these CD4 cells. If you treat between 3 and 4 weeks, there's already significant loss, and if you treat during chronic infection, there is a very, very large loss. And as you know, that doesn't come back. That loss is not going to disappear when you start people on HEART. If you look at integrated HIV DNA in peripheral blood mononuclear cells, if you treat during phoebic 1, so these are people who are only RNA positive, no P24, no antibodies yet, you see that the majority of these people, you cannot detect this integrated DNA. Phoebic 2 already, maybe too late, and Phoebic 3, a lot of them, you have detectable integrated HIV DNA. And then lastly, there is, in people who are treated within 15 days in that study, there is no detectable integration of HIV DNA in memory CD4 cells during acute infection. So these are all, I think, very tantalizing data. And then, of course, we have to go back to the prevention benefit. That's a societal benefit, which also is nice for the individual. And again, the possibility to task shift is also very important. In Africa, we cannot scale up if we don't start the task shift. We cannot, there are simply not enough doctors. And it's far easier to treat somebody when he's asymptomatic than when he's symptomatic. I work a lot in rural Tanzania at the moment. It's really awful how late people come. And they come to clinics where there are no doctors, and basically they die. So in conclusion, offering antiretroviral therapy as early as possible to HIV-infected individuals has major health benefits. It limits the size, if you treat acute infection, it limits the size of the viral reservoir and may even lead to a functional cure in a subset of individuals, about 15% in the French study, but these were treated quite late during acute infection, so I expect that in the Thai study many more people will have a functional cure. And we should really stop this quibbling about the right time to start HIV treatment. A trial like START is really, it's from another age. These debates are misguided, and they really detract us from a job that's difficult enough without this detraction. It's all about operations at the moment. And then there's the societal benefit of reducing HIV transmission, which may also be perceived as an individual benefit. And the world must be willing to surmount the enormous hurdles, financial, logistical, that stand in the way of realization of the opportunities that TASP offers. And one of the hurdles, of course, is that the upfront costs of putting more people on treatment are higher. But if you look at this modeling from Julia's group in 2006 in Lancet, you see that initially, if you treat all, the cost of treatment will be higher, but eventually you will save money. And there are several studies to support that. There's a paper from Ruben Granich looking here at lives saved. This is treating all, and this is staying with a CD4 cell guideline of, it's actually a wrong, 350. This is less than 500. So these are the lives saved. And then if you look at the cost, treating all, yes, you have a steep increase here in the need, in the money, but needed. But it also goes down quite rapidly. And we also have to realize that drug costs at the moment, certainly not if you look at if you look at the programs in Africa, the drug costs are not a major expenditure any longer. You can now get the very best regimen for $10 per month. There's a paper in last year's New England by Rochelle Walensky showing that in South Africa, early antiretroviral therapy was cost-saving over a 5-year period. And in both South Africa and India, early antiretroviral therapy was projected to be very cost-effective over a lifetime. France is to be complimented for being one of the first countries that really adopted TASP, and it's in good company because Brazil has also done that. Brazil has been at the front of fighting HIV for a long time. For a middle-income country, that's a great achievement. Lastly, I want to thank Jintanat, Anna Voranic, Julio, and Peter Rice from the HIV Monitoring Foundation, and I'll run straight into my next talk, if I know how to do this. So you can, if you have questions, it's best to ask them afterwards. So this is about the cascade of HIV care, because I can tell you nice stories about how we should increase. These are my conflicts of interest. I'm always suspicious about people that don't have conflicts of interest. But if you look how difficult it's going to be to really get everybody tested and treated, I think this was an eye-opener for me, this paper in CID in 2011, which looks at the US population. And this paper showed that of the 1.1 million people infected in the US, you lose about 150,000 that are not diagnosed. And then from those diagnosed, you lose about 200,000 that are not linked to care, then you lose another 120,000 that are not retained in care. And then of those needing antiretroviral therapy, according to the then time guidelines, in fact, almost 80,000 less get antiretroviral therapy, and those who have an undetectable viral load, you lose another 60,000 or 50,000. And the truth of the matter is that HIV incidence, so you end up with 19% of HIV-infected persons in the US having an undetectable viral load. And HIV incidence in the US has not declined despite almost 15 years of widespread access to combination therapy. And then also sobering picture from the trial, they modeled what would happen. So here we are, 19%. This was the current situation in 2011. If you would increase people with a known HIV status, you would actually go up to 22% undetectable viral load. If you would engage 90% of people in care, 34%. If you would treat 90% of those, 28% an undetectable viral load in 90%. But if you did all of that together, if you accomplished all of that together, you would still only be at 66% people with an undetectable viral load. If we then look at the Netherlands, these are the people who are diagnosed, and there's approximately 7,000 that's an estimate from UNAIDS, with unknown HIV positivity, so they don't know themselves that they have been infected. Well, if you look at the figure is much better than the US. The US was 19%, you have to realize, but here it's 53%. So much better, but then also social system, of course, has certain advantages over that of the Wild West. What is the case is that most of the new infections are coming from the people who don't know their HIV status. There's been modeling from the HIV Monitoring Foundation. So the majority of new infections are caused by people who don't know they're HIV positive. So one of the things we need to do is obviously get to those people and test them. And it's a bit similar to what you saw for British Columbia, but we have, over the past years, we've had almost 1,100 new infections per year, and 2/3 are in MSM. And there seems to be, this is similar in Paris, you see it everywhere, that MSM in Africa, in Thailand. There's this risky behavior in especially young MSM. We have 43% late entry into care, meaning with a CD4 count of less than 350. And actually 1 out of 4 patients that enters care in the Netherlands enters with advanced disease, meaning AIDS or having a CD4 cell count less than 200. So this is not a very good picture. And the median CD4 cell count at entry into care was 390 in 2012. So not so good, but the worst is that there's a delay in starting, so people come in late, but then there's a further delay in starting with therapy, so there must be also something wrong with the doctors. Yet, if you look at the people who are going into care and receive ART, the success rates are remarkable. 94% of the people have an undetectable viral load after 12 years of follow-up. So this shows what we can achieve if we get people into care and put them on the right regimens. Very similar cascade of care from British Columbia, yet to be published paper, but in a very similar number of people with an undetectable viral load, percentage of undetectable viral load as in the Netherlands, slightly better. And here you see, these are slides from Julio, the increasing heart coverage following guidelines in British Columbia. So this is phase 1, old guidelines, newer guidelines, and now with the current guidelines. And the new AIDS cases in British Columbia have really gone down dramatically since the introduction of HAART, as they have really gone down everywhere. And also all-cause mortality in HIV-infected patients has gone down very dramatically. And one of the most encouraging slides is actually this one. If you see how many more people are actually being tested, there's a very active policy in getting people tested in all different locations. And interestingly, despite the fact that British Columbia has a very active testing policy, what you see is that they actually diagnose less and less people with HIV infection, whereas if you look at another Canadian province, Saskatchewan, that it's dramatically the opposite direction. So more and more people with new infections, and unfortunately, mainly in First Nation people. They used to be called Eskimos in Europe, but that's probably politically incorrect now. And here you see the savings from averted HIV cases. So here again you see British Columbia as best in class. And I think I'll skip that one. Of course, one of the downsides of using antiretrovirals for HIV prevention and not using a condom is that you may prevent HIV, but you're not preventing other sexually transmitted diseases. And you see in MSM, you see really a steep increase in syphilis, something we've also seen in Amsterdam. So I'm almost finished. So this is the cascade of care in British Columbia over time. Sorry. And you see every step in the care cascade, there's actually been an improvement over time due to very active policy. And you see that health authorities matter because one of the health authorities is clearly underperforming. They have different health authorities in that province. And this is sadly showing that of the First Nation people, only less than 40% actually have a suppressed viral load. I'm done. This is my last slide. So what do we have to do? Well, we have to test. People who have a risk for HIV infection should be tested and tested again and tested again. We should make it easy to link to care. We need point-of-care assays, and we need to avoid delays. Now somebody is tested, then they get a positive result, then they have to wait, at least in our system, they have to wait several weeks before they get an appointment in the hospital. We have to do away with that. We need to retain people in care, and I think certainly a lot of people, it would really help if they had a personal case manager looking after them and making sure they are retained in care. And then we should be explicit about the benefits of HEART. We shouldn't be shy about it. We shouldn't be detracted by the start, people who say, oh, we don't know. We should actually point out how beneficial HEART is for individual health and prevention of honor transmission. And then we should really look after adherence by using single tablet regimens, having text messages. There are all kinds of ways to improve adherence. And I think still the very best system to improve adherence is what was done in Haiti by Paul Farmer's group in the early 2000s, is having a person going to the house of the people every day and making sure they take their tablet. Thank you very much.
So we have just time for one question, please. If there is not, so thank you very much.
There's a question.
Just one, yes, okay. Microphone number one.
Not Julio Montano, I hope. No.
Yeah, okay. It's a question for you, Joep, and also to Julio. It's about early testing and early treatment. If I have well understood your exposition, for women, the positive outcome of the treatment is not so quick as for men, isn't it? No. The results of the treatment, the outcome, the positive outcome of the treatment is quicker among men than among women, or not?
No, I'm sorry.
I'm wrong.
This was about Sub-Saharan Africa, and it was the time between infection and reaching a CD4. So this is not on treatment.
Okay.
In natural infection, reaching a CD4 cell count less than 500 was 6 months for men and 8 months for women.
Okay.
So women do better, as usual.
Yes,
yeah.
Okay. Thank you very much.
Thank you.